remind everybody to either turn your cell phones off or put them on vibrate so that they don't interrupt the meeting. Our meeting is being webcasted. If you'd like to provide public comment, there's speaker forms in the back, and you can give it to Ms. Sewell. Sewell, could
She just stepped out.
Oh, she stepped out for a minute. She'll be back. MAC members, a reminder that during today's meeting and all future MAC meetings, any items requiring a vote will be done by roll call vote. It means once a motion is made and seconded, Ms. Lowe will call each of our names individually to request our vote, at which time you can vote in favor, against, or abstain. Are there any questions? Great. The other thing I'd like to note is that if you come up to speak, and please do come forward to the mics to speak so that you can be recorded, please give us your name, and if you're affiliated with a particular organization, please let us know that also. Ms. Lowe?
That is voluntary. It's
Oh,
voluntary to
okay.
give your name.
But it'd be nice to know who you are. Ms. Lowe, would you please call the roll?
Dr. Byrne? Ms. Ehrlich? Here. Ms. Marcelin? Here. Ms. Jarosowski? Present. Ms. Barbon?
Here.
Ms. Corn?
The next agenda item is public comment on items that are not on the agenda. Is there any public comment now for items that are not on today's agenda? Okay. Ms. Davis?
Good afternoon, Rosanna Davis, California Association of Midwives. I wanted to ask if, for the next MAC meeting, if I could present on a plan for a quality care program for California licensed midwives. That's all.
Thank you. Is there any other public comment on items not on the agenda? The next item is the approval of the December 3rd Midwifery Advisory Council meeting minutes.
So moved.
You have to wait a minute. Because I didn't get these until yesterday, and I
Likewise.
just started reading them, and I have a whole lot of edits. So I would like to pin this agenda item to the August meeting so that I can get staff my comments and they can review the tapes and make any changes that need to be changed. And if other people want to also provide comments, I'll give everybody the opportunity to do that, and then we can look at them in August. Do you want to make that motion?
Sure, make that motion.
Second.
Second.
I'll take a roll call vote.
Wait. Is there any public comment on this agenda item? Seeing none. Any comment from the mat? Seeing none. Okay, now you can.
Ms. Ehrlich?
Yes.
Ms. Marcelin?
Sorry.
This is to plan the minutes to.
Yes.
Ms. Jarosowski? Aye. Ms. Barbon? Aye.
All right. So agenda item 4 is report from myself. And in the interest of time today, since we have a really full agenda, and I didn't have a whole lot that I needed to say that wasn't going to be covered somewhere else on the agenda, I'm gonna move us forward. Anybody want to say anything about this agenda item?
Since you didn't say anything, it's hard to
Okay,
comment.
good. We're moving forward here. Agenda item 5 is a report regarding the ability of licensed midwives to consult or collaborate as required by AB 1308. And Rosanna Davis of the California Association of Midwives is going to give us this report. Well, we can't see that at all from here. Can we move it?
It's on our desk.
It's in your packet.
But I can't read it through the dark.
You can come out here.
Okay.
We need to move over there.
Good afternoon. Thank you all for your time today. At the last MAC meeting, Katie Bueller asked who's part of the leadership team at California Association of Midwives, asked if we could put on the agenda for today a discussion about referral challenges that licensed midwives and their clients have. And so in order to inform that discussion, we thought that it would be helpful to hear from more than the midwives who are going to be at the meeting. And so we conducted a survey. Katie, do you want to say a couple words about why you brought up this topic? Yeah, go ahead.
Sure. So this came up for me last MAC meeting because Dr. Byrne was quite sure that we should be able to do the VBAC consult with a physician after one cesarean. He seemed quite sure about that, and I feel less certain that I could find physicians that are within my clients' insurance policies that would be able to fulfill that role. And additionally, the week before, we had 2 babies in a breech position at 36 weeks, 37 weeks, both babies, and we couldn't find anyone that would see those ladies in a timely manner. One doctor who was amenable to seeing them, he was going to be 4 or 5 weeks to see him. Another doctor, another medical practice, a very large one in our community, said, no, we can't see her. She hasn't been in our care. One of the other like Medi-Cal type accepting programs in our area wouldn't take her back into care since she'd been seeing us. And so it just was really, really difficult to get these referrals for these ladies so they could be seen for breech babies. And that was how this was inspiring for me to bring it to the attention of the MAC.
Thanks, Katie. So, for any of you that don't know me explicitly, I'm a licensed midwife. I practice in the San Francisco Bay Area for 11 years. And I'm part of the leadership team at California Association of Midwives. What the survey wanted to do was to bring some quantifiable as well as qualitative information to the conversation. And the questions were a variety of narratives as well as multiple choice, and tell us how many times that you've had referral issues for these types of referrals. So I'll go through some of the survey questions, the results, and then when we're done, just give you some overall impressions of the survey. And so did anyone here take the survey? So we sent the survey out to California Association of Midwives members. As well, we also sent the link to a Google group that is comprised of licensed midwives. We have around 200 licensed midwives who are members of CAM, and the Google group has around 100 licensed midwives. And the participation in the survey was 42 midwives, 35 of which were individual LM practices, 5 of them with 2 midwives, and 1 with 3 midwives and 1 with 4 midwives. So overall, the survey represents approximately 52 midwives, and all reported being California licensed midwives practicing in California. So as we go through this, keep in mind that it is a survey. It's not a collection of data, and so it will give us impressions and inform our conversation, and hopefully be able to come up with some solutions together. So here's a representation of one of the questions, and so let me explain this. There's a variety of ways we could have represented these, but what this says is, the question is, in the past 2 years, approximately how many times did you have significant difficulty securing timely care for clients? A full 31 of them reported that they didn't have a problem. Approximately 18 of them reported at least 1 to 5 times, and then a smaller number of them 5 to 9 times, and then one of them reported more than 10 times. So this could have been represented in a different way. If we could have put buckets of yes and no, I've had problems and how many times. But what I think what's important to see here is if you add up this bucket and this bucket and this bucket, that is approximately 30 times that licensed midwives had trouble with referrals. Similar question, how many times for a referral was there a non-urgent obstetrical issue that was not accomplished in a timely manner? Full 40 said no problem. If you add up those buckets though, there are full 33 incidences where they had trouble with referrals. And so the subsequent questions show the same trend. This one is for 42 weeks. This one surprised me. The other thing that informs this conversation is that being on the leadership team at CAM, I sometimes get people call and tell me difficulties that they're having. The first year that AB 1308 was implemented, I got a call from a midwife who was quite distressed about having transferred a 42-week mom to the hospital. She was not in labor. She declined induction because it was not medically indicated, and the baby and her placenta and everything was fine. She went home, waited for labor, however, gave birth unattended at home. She was quite distressed about that. Midwives want safe, quality care for their clients. So, this one was interesting. This is how many times have you had problems getting a referral for an abnormal prenatal screening result? Not very many reported this. I wonder if it's because a lot of our clients don't get prenatal screening, or if they opt out, rather. Number of times that the referral was refused for routine anatomy ultrasound. Number of times that care was secured, but it was expensive because the only option was the ER, or labor and delivery. Again, on the topic of ultrasound. This one, so the column on the bucket on the left says, no problems referring for ultrasound. And then the rest of them, if you add up all those other buckets, are around 17 incidences of difficulties in securing ultrasound for a variety of reasons. This is just a collection of fill in the blank about other referral challenges that you'd like to report. I printed them out for you so that you can take your time looking at them. A couple of them here that I wanted to call attention to. One is no ability to consult for prior cesareans. Another submission, stressful transfer to local hospital because both client and midwife are treated disrespectfully. Client seems to be punished for attempting out-of-hospital birth. Therefore, for non-emergent transfers, we drive to the hospital 50 miles away. One comment of note is we have excellent referrals. Now, I tracked down who said this, and this is also a midwife who, in her comments, reported that upon the implementation of AB 1308, she and her colleagues sent a PowerPoint presentation to all the local hospitals, informing them of the new law and what the new expectations were. coincidence or not, I think it's helpful if we can communicate more and give people the benefit of the doubt that sometimes maybe they just don't know who we are and what we do and what our scope of practice is. Last one that was of interest was referred client to local OB's clinic due to seizure during the second trimester of pregnancy. Client had no prenatal care for 8 weeks. I think there might be sometimes some confusion about what's expected when we refer. Does that mean that it's hands off now until they see the OB and then they're released back to care? Or is it true that we can continue and collaborate on the care? I would hope that midwives are doing the latter. I'm going to throw this one out. It's a difficult question to quantify, and we didn't capture it very well. Here's a yes or no question. Is it relatively simple in your community to have clients see an OB? If the OB knows that the client is planning a home birth or receiving care and all that, I think like most licensed midwives wouldn't find this at all surprising. But yes, it's a problem. How many OBs in the community are willing to accept referrals? This shows the results that, it goes from 0, 1 to 2, 3 to 5, more than 5, and not sure. I'm not sure why someone would be not sure unless they were new to the community or weren't doing a lot of referrals for whatever reason. I wanted to ask about Kaiser because in my area, in the San Francisco Bay Area, one of the best setups for home birth backup is the Kaiser system. They are very welcoming of our referrals. They're not perfect, of course, but neither is Care Anywhere. But I just wanted to know how many midwives had access, their clients had access to Kaiser Care. This next group of questions just asks on a scale, rate the, how much this is a problem. So on a scale of 1 to 5, where 1 is, it's a major problem and 5 is not a problem, is it ever a problem that OBs are uncooperative, making it rude or disrespectful comments to the clients or undermining their choices? So in full disclosure, the original question didn't say uncooperative, it said hostile. So if I were to ask this question again, I would say uncooperative. We didn't need to be disparaging. So this one falls in the middle for non-urgent issues.
Could you use the mic a little more?
Yes. How often is it a problem that clients find it necessary to withhold information about plans for a home birth due to risk of being dismissed from care? We have a setup in my area, for instance, where if you disclose to certain groups of physicians that they will give you a letter and say goodbye. We won't provide care to you anymore. This one surprised me a little. I thought maybe in the more rural areas that this might be more of a problem. It may also be that there are fewer births happening in the rural areas, or that fewer midwives in those areas reported in the survey. But it asks, I must send my clients an unreasonable distance to secure safe and timely or quality care. And then we wanted to just capture some demographics. How many total primary clients delivered under your care for the 2-year period? So 8 of them said 1 to 12, some 13 said 12 to 24, and the majority of them said 24 to 36
clients under primary care in a 2-year period. Please describe where you practice. The majority of them reported large city or major metropolitan area. Clearly, that's where there are more people or more midwives. And then some information about health insurance. So fewer reported having private health insurance that pays for most of the cost, or some of the cost of care with LMs. And then on the other end of the spectrum, either Medi-Cal or completely out of pocket. So, general impressions and some reminders. This is a survey, and it captured information from approximately 55 midwives out of 350 active licensed midwives in the state. It's my impression that it's not that the problems with referrals are not necessarily widespread or systemic. As I mentioned earlier, one of the midwives shared about sending a PowerPoint and being proactive in communication with the local hospitals and medical care providers. However, even if it's not widespread and systemic, even if one mother-baby couplet doesn't get appropriate and timely care because they're being discriminated against for whatever reason, that's a safety problem. And it needs to be looked at and addressed. So one avenue that CALM plans, so for anyone who doesn't know, CAM is bifurcating this year into 2 organizations, so that the second organization can be specifically focused on the professional needs of California licensed midwives. So that's why I say CAM-CALM, is that you will soon be 2 organizations. There are plans to implement a comprehensive quality care program from CAM and CALM. And it will include our own professional standard of care and proactive communication with hospitals and possibly a letter writing campaign to OBs. There are many other elements to the quality care program that I alluded to earlier I'd like to talk about at the August meeting. Does anybody have any questions about what was presented?
I think it's excellent, but my question would be, is the number of people that responded, could you tell, were they mainly from what areas of the state? Or is there any kind of like overview of, I heard you say that there's more babies born in metropolitan areas, I understand that, but are we seeing that maybe in Northern California there's more positive engagement with collaboration with providers?
The study didn't capture that, or the survey didn't capture it, because it didn't ask specifically what region you practice in. But I think it could inform another survey.
I think when you get time for another survey, definitely you should include some kind of demographics like that.
And in another survey, I'd also really like to know on of the women who are self-pay, how many of them are Medi-Cal eligible, and how many of them simply are self-pay? I'd like to see that split down. I think that would be good information.
All right.
Can we have the lights back, please?
Thank you.
And in one place you got that the participation had 42 responses, but it represented approximately 52 midwives. How did that happen?
If we go back here to, I think it's the 4th page.
Some are group practices that were reported.
Some are
as a
group practices. There we go. So 42 midwives responded for individuals and for group practices.
I understand what you're saying there. I'm not sure how that difference works in terms of what information you've gotten. I'm not.
It's a survey.
Right, I understand that, and
Yeah.
I'm not even clear what my question is, so let's forget it.
Okay.
Are there any other questions?
So if anybody wants to get involved, we need more people for our speakers bureau to go and talk to hospitals and doctors. I'd like to suggest that we submit an article for the medical board newsletter, much as Karen did, was it Karen? Did some years ago in a VBAC issue.
Yes.
I don't know if that's been done.
I don't think that there has been anything from licensed midwives in the medical board newsletter since that article.
And just to keep discussing how we might improve this situation.
One of the answers to one of the questions was that they had no problems because they had gone forward and disseminated information PowerPoint to local hospitals, and they had received positive interaction and engagement. I think that model is an excellent model, and it's something that you should be taking a look at as you move forward, to use them as a resource in helping you to buy some kind of a program.
Agreed, yes, I've been in touch with her, have her PowerPoint, yeah.
I would, on the page number 26 about the general impressions where it says it's not necessarily widespread or systemic, I would like to add on that, according to those who responded, because I'm hearing a whole lot more than what is represented here, and we can't know without,
Agreed,
yeah.
that's,
But I'd like it, I think it would help for that to be qualified on that line, that qualification be added so that it's clear, we can't really know.
duly noted.
Thank you.
It's a survey, it gives
It's
us
a
some
survey,
impressions.
yeah, I understand. I understand.
So, that's my conclusion, that's my
thank you.
story, I'm
Yes.
sticking to
Thank
it. I
you
hope we
very
have some more
much.
discussion
Yeah.
about it today.
Shannon Smith Crawley?
Good afternoon, Shannon Smith Crowley, representing American Congress of Obstetricians and Gynecologists for California. I'm very pleased to see that the survey was done, and a good starting point. One thing I would like to add to your list that's not on there is I would like to reiterate ACOG's willingness and desire to work with you, especially on a local level. Medical care is delivered locally. Every place is going to be different, and all you may need in certain areas is one physician champion who's willing to work with the hospitals. And you have pockets where there are good working relationships. We don't have Dr. Byrne here today, but it sounds like at Santa Clara, they've got a great relationship. This is also a very complex situation where we need to look at, again, the geographic areas, because it may vary on the physician's liability coverage. That's why Kaiser has a whole different situation than some others, because they're self-insured, as are University of California medical centers. And UCSF in particular has said that they would be very happy to reach out and to do work. And I think there's also a difference in which kind of referrals, if you're looking for some of the things that are just the consultations that can be done by telehealth versus the in-person care, and the referral, for instance, at 42 weeks is going to be different. And then it's going to also depend on each woman's own commercial insurance, if she's commercial insurance or Medi-Cal, and so that adds another complication. Most women should be having coverage under the Affordable Care Act, that almost everybody really should have Medi-Cal or commercial insurance. And so it's a real anomaly at this point if they don't. And I would actually find it very interesting to find out how many don't, because they're going to get penalized for failure to have it. And even undocumented women can get coverage because under the CHIP program, the fetus is considered the person and the citizen, and they can get that coverage. So you really shouldn't have an issue. So I'd be interested in if there is a problem in following up with that.
Shannon, the biggest problem is very high deductibles. They can be as high as $5,000
And
in order to
$6,000.
make them affordable, and so that doesn't really do anything for the client. And the other issue is managed care. We have a terrible problem, especially in this area, because the managed care doesn't cover the person for their midwifery services, and so they can actually get it cheaper, a less expensive birth by coming to us because their deductible is so high.
Right.
It would cover. The other thing is in the managed Medi-Cal. We understand that the law says that Medi-Cal women can choose by asking their worker to opt out of managed Medi-Cal and get straight Medi-Cal, but they're denied. It's a huge hassle. Nobody can follow up for 6 months on this sort of thing. And so
And
it
licensed midwives
sounds
can't take it anyway.
good on paper, does not really translate into everyday experiences of everyday women.
And I completely concur with what you're saying. That is our reality as well, and that's actually something we've got a number of groups, but one group in particular, and that we can work on this issue where if there's an insufficient network issue, that we're able to go sometimes out of network, or as you said, go to regular fee-for-service Medi-Cal. It is an extremely complex area. So absolutely, but that is something that, again, we're dealing with every day, and I think together that we can parse through and start pulling apart at these different issues.
One other issue that I have run into in the past about those who do have insurance is that some insurance companies won't cover home birth at all. And some plans within the insurance will not cover home birth at all. So some of those women, even though they have insurance, theoretically cannot get any help for their birth care.
But and that is an issue, and we can look into some specifics on that, but if you're specifically looking for the problem of failure to be able to get a referral because of odd insurance issues, that's where I was talking about.
Yeah.
But
Shannon, do you think ACOG as an organization might be willing to interface with CAM/CALM in terms of maybe putting together some presentations for physicians that in helping with the receptivity there? Is that what you're saying?
I've got Dr. Greg back there, who actually as past chair can speak to this. But let me preface with, we had an issue a number of years ago, probably 10 plus years ago, with clinics that provided abortions, and that when somebody had complications, they wouldn't go back to the clinic and they show up in the emergency department. And there was a lot of turmoil about that. And I think that was in some ways an easier topic. We were actually able to meet on local levels and get some communication going, get some protocols in place, and be able to really resolve that. And that's not been a significant issue. There's a lot of similarities to this about the transfers, at least in the emergency situation. So I think it behooves everybody, including our members, and our patients, and to be able to work together on
Yeah,
some of the
absolutely.
presentations. So I think
Okay.
we should be able to.
So maybe you two can hook up and discuss further.
Good. I wanted to
That'd be
point out
great.
one more thing
Sure.
about the survey, is that I've included the detailed narratives that people provided. And that gives a whole other picture. So please
Thank
take
you.
the time to read through those.
Yeah.
Super. Were you finished, Shannon? I'm sorry. Is there any other comments from the audience on this agenda item? Any other comments from the MAC? Right, seeing none, we're going to move forward. So the next agenda item is an update on midwife assistant regulations.
Thank you. An interested parties meeting was held on February 3rd at the board's headquarters to discuss regulations needed to define the training requirements necessary for a midwife assistant to practice in California. Business and Professions Code Section 2516.5, which went into effect January 1st, 2016, requires that a midwife assistant have at least minimum amount of hours of appropriate training pursuant to the standards established by the board for a medical assistant. Based on this section of law, the medical assistant regulations were used as a starting point to draft the regulations for a midwife assistant. In addition to the medical assistant regulations, the laws pertaining to midwife assistants were reviewed and discussed as they clearly define what a midwife assistant can do. Each item was discussed individually to determine what the appropriate training should be to perform that task. Following the meeting, board staff compiled all of the information provided to create the proposed midwife assistant regulations that have been provided in your meeting packets today at tab 6. I'd like to point out that although there are not currently any education programs currently being offered for midwife assistant training, we included the language in the proposed regulations so that if a program is created in the future, it would allow for this. This would include providing a pathway to obtain training through a program as well as for approving the certifying organization. We are aware of some minor edits that need to be made, which Ms. Webb will be discussing momentarily. But after review of the language in your packets, we will be asking that the MAC approve the language, and then we would be referring it to the board for recommendation. We would be recommending that language to the full board at their next meeting if possible for approval, so we can continue with the process. So that concludes my update. Ms. Webb will be discussing the edits and additional information.
Thanks, Natalie. There are a few areas where we want to add CNMs under 1379.01, under 1379.05, 1379.06, A1 and B. And then under 1379.06, we need to update the title for the Bureau of Private Post-Secondary. It should just be education. So we're striking and vocational, and then we're updating the section numbers. These were modeled after our current medical assistant language, and there's been some changes to the title in the relevant sections, so we will be updating those. And under 1379.07, also striking and vocational from B1B. I'm sorry, B3B. So those are the minor edits that Ms. Dobbs and I found.
So I have a few that I just need some clarification over, and some of it may be things that were pointed out in the interested parties meeting. So forgive me for asking again, but I think that there are people in the audience that are going to want to know the answer, and I couldn't remember what it was. And 1379.05A, I think or should be struck there. It should be and, because skin tests and injections are different than venipuncture for the purpose of withdrawing blood. They're two different skill sets.
And does each of them need 10 hours?
No.
That's part of why I read that as being reasonable when I looked at it. I don't think they need to have 20 hours between them to train an assistant in that.
I don't have my
Skills.
notes with me from that interested parties meeting, but
I think that language was also lifted from our medical assistant language. So if
Okay.
it's not something that is appropriate for midwife assistants, then now's the time to
well, I
discuss it.
I would think a total of 10 hours would be sufficient in
Yeah.
training for venipuncture and administering injections, the two things combined. Because then you're also going to have satisfactory performance of 10 injections and 10 skin tests. And again, it should be not and or 10 venipunctures and 10 skin punctures.
In the training.
I'm not sure how skin puncture differs from venipuncture. Oh, okay, skin puncture like is in a, no, for withdrawing blood. We're talking about a finger stick, okay.
or injections, IM injections are not venipuncture.
No, that would be an injection, but there's also, see where in B, it says skin puncture for the purpose of withdrawing blood? I think we're talking about going into the vein and collecting vials of blood, that's venipuncture.
Right.
Skin puncture is a finger stick for like a home hemoglobin or something.
Or a sub-Q injection. Well, but
Well,
you're
no,
saying
it's-
that would be injection.
That's
Okay,
injections,
okay.
yeah. Yeah, they're two different skill sets. So my edits there would be to strike or in A and or in D.
And I would say we don't
And
have
get
to
us down
strike
to-
them,
10 hours total.
as long as it's 10 hours total, yes. We don't need 20.
Say that again, Carrie.
Why don't we
Oh,
just
it's
put
in
A and-
A, in
I asked Carrie to clarify.
In A and D, I would just have it be and rather than and or.
Okay.
And take A and B to a total of 10 hours rather than 10 hours each.
In other words, A and B could just be combined for 10 hours,
Right.
instead of having them be
Or
two
they could
line
be
items.
or they could be 5 hours each if
hours
you wanted to
each.
separate them.
So if that's the case, then why then wouldn't it be A, whatever is listed in A, or B?
No, because they're two different skills. A is a different skill from B.
Okay, so
So
are
they
you,
need both. They need and.
so are you saying then that it's not 10, you need a lesser number?
You need 5 clock hours for A and 5 clock hours for B.
Okay, so that's what the change should be then?
Yes.
Instead of being that specific, what if we combine A and B, 10 clock hours of training in administering injections, comma, performing skin tests, comma, venipuncture, and skin puncture?
That'd be fine.
Okay, so
Yes.
combine it.
I'm going to hold the audience comments until so that we can kind of go one at a time? Or do you want to take comments on that section first? Okay, let's do it this way. Let's take comments on this section, and then we'll move to the next section. So 1379.05.
So we're just unclear about what skin tests. Are we talking about TB tests?
Yes.
And licensed midwives don't routinely do
No,
TB
but
tests?
in clinic settings, they do,
Okay.
yeah. And so do their assistants. My assistant in the clinical setting does TB skin tests.
Is she a medical assistant?
She is, but we're looking to train just midwife assistants, and they'd need to have that skill as well.
Okay. And so licensed midwives would supervise that?
Yes.
Hello, I'm Kate Boland. I'm a nurse midwife, and I've done home birth for over 40 years. And my question is, why are you putting hours of time on these skill sets?
Because we're required to make them somewhat mirror the time requirements that are in the medical assistant language.
Okay, so you're already required to do that,
Yeah.
because, so the teachers would have no discretion. It's like some people get it on the first blood draw, and some don't get it for months.
Right. Some of it is didactic, just the theory in how to find the vein, what the complications might look like, blah, blah, blah.
Okay.
Do you have something to say, Barbara?
Not in this section.
Okay. All right. Book training.
So maybe it does apply to this section. So in the training of performing services, there's nothing in this section that tells you what skill set you might need to do to be an assistant in a home birth. Other than, it doesn't say you need to attend X number of home births with a midwife who's doing the training. So, you're you're doing all this book knowledge, you're learning how to do all these puncture injections, skin tests, oxygen, how to treat the newborn, and how to place a device, and how to read a book, all the book stuff, but you're not being told, there's nothing that's telling the assistant that they have to attend X number of home births as an in-training process with a licensed midwife. So how does the person walk into the room able to be an assistant if they've never been expected to be participatory with a certain specific number of home births? Should that be part of it or not? I'm looking
No.
at Faith.
We're not, the law didn't dictate that we put that in. No licensed midwife is going to take an assistant with them to a home birth that's never been to birth before as other than the assistant, so assistant in training even.
How does one learn to be an assistant if one isn't expected to have participated with being there, present?
Can you
I don't know.
help me out with the medical assistant language? 'Cause
So,
I think that's where it's from.
As we all know, assistants are unlicensed. They have very little training.
Right.
And so when they are going to a birth, they can go to a birth and start, charting and documenting as the assistant because they've already received the training and expectations from their supervising midwife. And so the midwife can provide basic training outside of the home birth, and then some of the stuff they'll be getting instructions all along, but the midwife has to set appropriate limits because it's as if she's performing the services herself, and it's her license that's on
Now,
the
the limits I
line.
understand from that end. I was from the front end going forward. I was more concerned, should an assistant be expected to attend alongside of, with a licensed midwife a certain number of times before they're able to become an assistant? That was where I was going.
I believe that's the discretion of the midwife.
Okay.
All right. I'm sorry.
Thank you. Anne Marie Adams, OBGYN, practicing in the Greater Sacramento area. And I wasn't asked the question, but the question that was last asked about attending a certain number of births before being certified, I don't think should be up to the discretion of the licensed midwife. I think there should be a certain number of hours, just as medical assistants have a certain number of hours of on-the-job training, because that's when you're in the trenches. But I came up here speaking to 137905, that I think the number of hours for training in venipuncture, skin test, et cetera, of the didactic, and some of these other things is excessive. I think 10 hours is not necessary for the skill set that's required for a midwife assistant.
Yeah, we're going to take it down to 5 for that. And I thought we're going to, the A and B are going to be combined a total of 10 hours, so 5 hours for each.
That wasn't how it was left. It was just going to be combined, total of 10 hours, and you can allocate
Right.
it appropriately.
That's right. So half as much time as what's currently written here.
Yeah, I still think that's excessive for what's being done and the didactic teaching and the organ system that's involved. It's all similar in organ systems, and I don't think that 10 hours is going to be necessary for all of that.
I do.
And in addition, they still have to satisfactorily perform. So 10 hours you're saying 10 hours is a minimum. We're setting minimum standards. So I think 10 for those A and B is excessive.
What would you think would be more reasonable?
I think 5. I think 5 would be.
For the two combined?
I think for the first 3, 5 hours
Yeah.
would be.
I actually do agree with that, and the only reason I wasn't saying anything was given the mirror that we're supposed to be doing with the MA law or requirements. But I do think that this is excessive. I think that when I said that a lot of the training is at the discretion of the midwife, I think that has to do with these particular skills as well. That, yes, we can have some certain minimums, and we have to be careful that we're not just making busy work.
It seems to me that the law requires that we mirror medical assistant language, am I right? And there are regulations for midwife assistants that are very specific about the number of hours. So I think we need to be sure we're catching the same number of hours there that medical assistants are having, whether it feels unreasonable or not.
Yeah, I agree that there's some things aren't.
So it
Dobbs
says,
has something to say.
25
it says, my own.
Not yet.
And has had at least the minimum amount of hours of appropriate training pursuant to the standards established by the board for a medical assistant pursuant to section 2069. So you would look to
That regulation,
the
right?
regulations established under 2069 and mirror it according to that.
What was that section again, please, Diane?
2069.
2069, but you'd have to look to the regulations that were established for medical assistants in accordance with 2069.
Thank you.
Let's see if I can find those. May I speak? And that would be 1366. Let me look at 1366.
Sorry, my name
Go
is
ahead.
Kiki Jordan. I'm a licensed midwife.
Thank you.
I just wanted to bring up the issue of access when you compare licensed midwifery, midwifery assistants to medical assistants. It's probably easy to obtain 10 hours of this kind of training if you're in a clinical setting.
Yeah.
But if you're attending home birth, it would be difficult to get 10 hours of IV or venipuncture training. I know we have to.
I think the training is not, it doesn't necessarily, and probably ideally would not be on actual patients, but would be like a workshop conducted by the midwife where, people volunteered to be poked.
Or it
Okay,
could be
And that would
models.
qualify under satisfactory
Yes.
performance. Okay.
Yes.
It could be dummy models as well.
Yeah, it could be that as well. You'd be using models.
Okay.
So what does it tell us? You want to read it for us? Thank you.
So looking at that section, it's section 1366.1 of the regs, training to perform venipuncture, injections, and inhalation of medication. And in that section, it specifically lists the 10 clock hours.
What I thought.
Right, that's where it comes from.
Okay.
For all those things?
So I'll tell you which ones. It says
Or 10?
10 clock hours of training in administering injections and performing skin tests, and/or 10 clock hours of training in venipuncture and skin puncture for the purpose of withdrawing blood. And then it goes on, and satisfactory performance by the trainee of at least 10 each of intramuscular, subcutaneous, and intradermal injections, and 10 skin tests, and/or at least 10 venipuncture and 10 skin punctures. And then there are others as well.
So it seems to me that we have to leave it. Am I right or not?
Wait, in your English, the language that you're using is using hours and procedures in the same and/or sentence. And what you're trying to do is delineate out and separate out hours and procedures.
No, it's just like it is.
So-
It's just like it is here,
You
Barbara.
have, if you have A, it's 10 clock hours, but
And/or
and-
B.
B are
Okay, but
hours.
C is.
And then
C
is
and
at
D
least- It's procedures.
are
C
procedures.
is separate, though, from A and B. it doesn't, C is standalone, and then D is a sentence that stands
So
alone.
in
It's-
A and B, which you're combining or you're not combining, you've got hours. And in C, you're suggesting procedures. So is it 10 hours plus 10 procedures?
Yes. But what I'm not clear about, and I'm going to ask legal on this, is in A and B, does that terminology and/or mean it's a combined 10 hours or it's 20 hours?
No, combined.
Well, and/or, it's
Either.
10 hours in this or
Right.
10 hours in that.
Yeah.
So then it's just 10 hours, and so then we have what we asked for.
I think there's some
If we leave and/or.
flexibility here, and it probably depends on how you're going to use your midwife assistant.
I think one of the things that we need to look to also is that as time goes on, there will be programs that train midwife assistants. They won't all be trained one-on-one with a midwife that they're going to assist. And so we want to be sure that in a classroom setting, rather than in an actual practice setting, they're getting enough experiences so that they're competent.
You might want to go back to the original language is my concern.
Yeah, I think
That's
we
what I'm
have to.
I think
thinking.
you have to go back
Yeah.
to
I
the
think we
original
do.
language, I really
I
do.
think that's right.
It may seem excessive, but down the road, as you explained it, you want to make sure.
Yeah, because I think we don't have the option, given the way the statute is written, to deviate from it.
Yeah.
May I comment?
Please.
My name is Nancy Myrick, and I'm a home birth midwife in San Francisco. My concern, and I understand that this is based on a reflection of medical assistant language, but there are a number of requirements in here that are skills. If you're talking about a midwife assistant at a birth, these are things that she will never do.
Yeah.
And I'm curious why it's a requirement that she has to do these.
Like, for an instance?
For an instance, a skin test.
Well, like I was just saying, you could, as this broadens, you may have midwife assistants working in clinical settings where skin tests are done.
Yeah, but that, I guess my question to you is, if we're training midwife assistants who are, at least I think in the experience of all of the home birth midwives I work with, we use them at birth and not in any clinical settings. That's 95%
That's
of what
now.
they would do. I
We're
understand.
looking ahead, and actually the clinic system that I work in wants to be able to utilize this because we have a really big perinatal program, and we can't find enough medical assistants. This would allow us to train people as midwife assistants, and they could perform very similar functions to
So
what
you're
MAs do. so-
Essentially creating MAs for midwifery practices.
Yeah.
Okay.
Yeah. Okay, so basically this language is just pulled from the MA language, and we pretty much need to
Stick with
need
it.
to stick with
Yeah.
it. Got that, okay.
You've got somebody at the desk.
Oh, sorry. Kate.
I just wanted to, Kate, I just wanted to address your question, Barbara, about how do these assistants get on-the-job training? It seems like after someone does the didactic, gets their assistantship, it is on-the-job training. I'm not sure you want to put it in the law that they must attend so many births. I think there's enough flexibility. There'll be clinic settings, there'll be office settings, and there'll be birth settings. I think anybody taking on medical, a birth assistant on is going to have their own way. And having trained many birth assistants and many apprentice midwives over the decades, there usually is a process where they're the third at a birth, and they get trained by the assistant. This is how this midwife works. This is what her procedure, this is what her birth kit looks like, blah, blah, blah. And that, I think, is a general thing that happens. But I think to say you have to go to 10 births as an assistant before you can be an assistant is like a catch-22.
Okay, thank you.
Thank you. So I have some questions in 137906 that I think we talked about in the interested parties meeting, but for the benefit of the audience, I just want to look at them again. An agency recognized by the United States Department of Education, that does include MEEC, right?
Yes.
Okay. MEEC,
Midwifery Education
Education
Accreditation
Accreditation
Council,
Council.
which is recognized by the Department of Education.
And then this language is lifted from somewhere else, am I correct? Okay. So I'm wondering if public school refers to a community college, for instance. Because instructors in community colleges are generally master's qualified rather than credentialed. And so I'm just,
That may change.
yeah, well, if you've lifted the language, I guess there's nothing we can do about that, but.
I don't think that changing the language would benefit anything, unless you can explain how it would.
I think that it's an undue burden in my thought process. If I want to teach midwife assistants at a community college, for me to have to go and get a teaching credential first.
Okay, the term instructor doesn't necessarily denote a master's trained or PhD trained person. The term instructor separates out the term professor from a non-professor.
Yeah, my problem is with holding a valid teaching credential.
Not there, does it say that there?
Yeah.
It says
Shall
further down-
possess a valid teaching credential issued by the Commission on Teacher Credentialing. Which I think
Oh,
may
that's-
be
I'm sorry, I didn't read the end of the sentence.
problematic. And I thought that since this was mirroring medical assistant language, and medical assistants can train other medical assistants, that midwife assistants could train other midwife assistants, and licensed midwives could train them. I'm not sure why, except that we're getting language from somewhere else. How much room do we have to change the valid teaching credential?
For private, it doesn't state that.
Yeah.
For medical assistants, you have to be a certified medical assistant to provide the training. Now, I do want to go back to 1379.05 because I think we can consider adding a paragraph that you have to have this training in order to do these things and not just apply it to all midwife assistants if they're not going to be doing, venipuncture and skin tests and that type of thing, so that you can start as a midwife assistant doing charting and taking blood pressure and the like, but if you're going to do venipuncture and skin puncture and skin tests, you have to have these certain hours of training.
That
So
makes
there should
sense.
be an intro paragraph there. And I also want to explain a little bit more about the process. So we're working out some of the language here.
Right.
This will be presented to the board, so there will be additional time for public comment at that time. And then there's going to be a formal notice of the language. It'll have a 45-day comment period where people can make additional formal comments. And then there will be a formal hearing
Right.
where more comments are made. So this isn't an end-all be-all today, but we do want to get it in the best position possible.
Yeah, I'm just hoping if we can get as many questions answered today, that would be really good. So back to my question on .06 with the valid teaching credential. Is there room to change that language at all?
Can we just strike that sentence?
If you want to protect people from private schools. It does say in public schools.
But there,
Okay, I'm sorry, I was looking at something else. Which section are you talking about? What sentence?
1379.06.
Sentence.
A2,
It's fourth line up from the bottom of that paragraph, the instructor in a public school setting shall possess a valid teaching credential.
And if you continue on with the next sentence, the private post-secondary institution shall meet the requirements of section 94310 and 94311, what does that state? My concern is that to see private entities popping up to do this and charging a huge amount of money. Right, but what is 94310 and 94311 state?
So those,
Are they more vigorous or less vigorous, I
That's
think
what
is
I'm wondering,
Barbara's.
yeah.
those are the requirements that the post-secondary, I'm sorry, the Bureau for Private Post-Secondary, those are the section that governs recognition of these different programs. Those are the code sections that
But we don't know what those requirements
I
translate to.
don't have it in front of me, but it's the requirements for those programs to be recognized by the Bureau for Private Post-Secondary Education. That's what that is.
I guess the question is, are they significantly different than for a public school? In terms of what the requirements for the teacher would be. It's like if we're going to have,
Can I make an interpretation?
please,
So the way I read it, it says, a licensed midwife, I'm in number 2, a licensed midwife shall serve as advisor to the midwife assistant training program. Okay. Then you go down below and it says the supervising licensed midwife shall certify in writing the place and date such training was administered, and that the midwife assistant was observed by the supervising licensed midwife to demonstrate competence.
right, but it's or instructor, or instructor, or instructor, and it's
Right,
instructor
so-
I'm trying to define.
So instructor, but you carry as a licensed midwife supersede the instructor in this situation. You are the instructor because you're the licensed midwife, or you have a proxy that you're supervising who is the instructor. Yeah, if you're gonna have this at a community college, you would have an instructor that's under you that you're supervising.
But I see advisor as a different role than instructor.
Yeah, but the second paragraph, paragraph B, basically gives you permission because you're the supervising licensed midwife who will certify and who will observe and who will sign off.
That's for the midwife training, the midwife assistant, him or herself.
Right.
Right. Yeah. So I don't think it applies to the,
The issue is the application of that sentence within the public school setting. It doesn't add or detract from that. The public school setting still defines the instructor as being someone with a credential. You see the fourth line up in that paragraph B?
I see it. I just think that when you're,
Doesn't mean
as someone
anything.
else said, when you're in a community college setting, you don't have, you're not credentialed.
Yeah.
right. Yeah, that's what I was saying. That's why I was confused why that requirement would be there ever, because you don't have to be credentialed in a post-secondary education program, public or private.
And I can't imagine that we're going to be training people in high school
No, probably not.
to do this.
So
Medical magnets in elementary school now. Did you
I would say if there's a way to get rid of valid teaching credential, we should get rid of it.
Ready to work as medical professionals? No.
I think the instructor should be qualified by the legislation to teach the course, which means that she's either a CNM or an LM. Correct? I mean, that's who can train midwife assistants.
Yeah.
And there's no requirement in the legislation that we actually have a teaching credential in order to teach them.
You know what, I think what this is talking about is if you are teaching in a public school, that you have to have the teaching credentials that's required by the Commission on Teaching Credentialing. I'll have to check, but I'm not sure that this is referring to the community college settings.
It seems to me that it would just be cleanest to take that sentence out.
Yes,
We're
but
not, we're,
When you're talking about education, just because somebody's a licensed midwife does not mean they know how to educate. So that it doesn't mean that as a licensed midwife, they can't be part of the education, but it needs to be supervised by somebody with a teaching credential to go. If it's going to be the same as the medical assistants, at me as a physician, that means I can't train medical assistants.
Yeah, but you can by law.
Yes, you can.
Yes, I can. Yes, I can.
As licensed midwives, we're authorized by the statute to train medical.
But that's not
to
what I'm
train
saying.
midwife
You
assistant.
want to take out the teaching credential from the second section. The first section, as a supervising licensed midwife, you can train anybody you want to, under paragraph 1.
Which she's, you're
Under
reading it right.
under
If you are,
paragraph
and
2.
it says, if you are in a secondary or post-secondary or adult education program, then you have to be.
If you're going to start a
Then
school, you
yes.
need to know how to teach.
That's very good clarification.
And you should be educated on how to teach.
We've been reading it differently, have been reading it differently. So thank you for that clarification.
So you're saying in section 1, it's the individual midwife
One-on-one.
may train. And in section 2, we're talking about in a school setting.
Right. If you were to go and take a course in a secondary, post-secondary, or adult education
And you're
program in a public school,
And you're charging money.
then you must be a licensed, credentialed, valid teaching. That makes total sense. Thank you.
Thank you.
Thank you.
I thought you guys.
Well, I think what I'm hearing is that if you're going to set up a formal program in a public institution, then the people doing the teaching need to understand how to teach.
Exactly.
They need to be credentialed.
Yeah. Right. It wouldn't apply to me teaching, for students at home.
No.
In a
Carrie,
private
I
setting.
thought you were saying, could a midwife teach in a post-secondary education program without having a teaching credential?
That's what I thought you were saying too.
Well,
But the clarification.
She can.
I was.
Yeah, but now,
Actually.
now with the clarification, we're back to the way it reads, correct?
I think
We're
so.
talking about only if it were to be offered in a program in a public school, then the person doing the education has to be a credentialed teacher, and that,
Yeah. Because no matter what kind of regulation we write, the public school itself is going to have rules about who gets to teach there.
Right.
I may be the only licensed midwife of my age with lifetime teaching credentials, so you can volunteer me, but they're
Okay.
going to have the rules themselves that we can't do anything about, even if we write a regulation.
I'm glad we had this conversation because I would have never sorted this out on my own.
Yeah.
Does anybody else have anything to add to this paragraph? All right.
I do have a question, a clarification
Okay.
question. Faith Gibson, California College of Midwives. When the LMPA was passed, there was a statement that it was to be equivalent but not identical to the nurse midwifery licensure. And so my question is, does the word mirror kind of nail our feet to the ground to being exactly the same as medical assistant, or is it that quality of equivalency? In other words, that there is formal teaching and the topics would be different if you were a medical assistant than if you were a midwifery assistant, obviously, so that's one obvious difference already. But how much wiggle room is there? Actually, I think the lawyers here, Carrie probably has my answer.
Well, Business and Professions Code, Section 2516.5 sets forth the requirement for a midwife assistant, and that person has to be at least 18 years of age and has had at least the minimum amount of hours of appropriate training pursuant to standards established by the board for a medical assistant pursuant to Section 2069. Now,
So it's just the hours of training, but not what the training is.
and for doing those certain things. This particular statute for midwife assistants goes on to lay out some of the things that midwife assistants can do, that those aren't referenced for medical assistants.
Okay.
You
So
know,
we're not trying to take a shoe that's a different size and make it work for midwifery training and midwifery.
No, I think it's where the things overlap, we have to have
Okay.
the
And we
same
can
training.
add to it. You were just talking a minute ago about adding something, which I think that would be excellent.
yeah, there needs to be an intro paragraph for venipuncture and skin tests that if
If you're
the
not
midwife
doing those
assistant-
things, then,
Right.
it's a different category. Thank you.
All right. Okay. I remember in, let's see, 1379.07, approved certifying organizations. I remember that we talked about what is written in B1 on page 16 of our packets, is a nonprofit tax exempt organization. I know this came up and somebody explained why that had to be there, and I don't remember why, and I'm sure other people would like to know why.
Where are you?
I'm on page 16 of our packet. Here. B1.
Yeah.
It's a,
I think it's protection of the person, just financially.
Protection of whom?
the student.
Kate, just one quick comment. Where you were adding CNM under 137901, also add CM, because the American College, we have certified midwives that are nationally recognized with master's degrees.
Yeah, and they're not in our legislation, unfortunately. Missed that. There's some cleanup for somebody. They should
They
have
have
been.
to be in your legislation?
Yeah.
They're not specifically authorized by our legislation.
But CNMs are?
Yes.
Yeah.
Licensed midwife, certified nurse midwife is what's there.
I
Yeah,
think,
that's a cleanup thing.
yeah, I think it has to do with the fact that CMs are not licensed to practice in California.
Yes, they are, they may
They
be.
are now?
Yeah, I think so. I'm not sure about
I
that.
don't
I
think
thought
so.
they were.
I don't
No.
think so.
Do not
Only
believe
if
so.
they take the steps required to get licensed.
Be an LM.
Easier.
I know. All right. That's all I have. Does anybody else have other edits on this? Any other?
I know I keep on being a broken record on this one, but I keep coming back to those who are certified professional midwives who are recognized nationally and internationally as qualified to be midwives, but are not automatically licensable in California. I believe they should automatically be authorized to be midwife assistants, and I see nothing in here that makes that work.
We decided not to do that in the interested parties meeting because somebody has to verify that they have what they have.
And I would
And
say
there's
that the
no
North Ameri-
mechanism in Karen in California to automatically verify a CPM credential or the credentials of a midwife coming from outside the country. There's no way to look at that other than an individual licensed midwife going through the steps and verifying and certifying the person that they can do that job.
Interestingly, I don't remember that at the last meeting.
Interesting.
And I apologize if indeed I am just being a broken record. I would like to go on record as saying that I think this needs to be changed. We need to figure this out. Somebody who is qualified to be a midwife can assist. And essentially, those,
Yeah, there is no mechanism in California for that
For
to
that.
work, and it would take legislation to make it happen.
okay, and I'll stop
yeah.
talking about it from now on, I promise.
We really did
It-
vet it in the
Right.
interested parties meeting.
So the bottom line is, to be a midwife assistant, it has to be any unlicensed person. And they are unlicensed persons. So as long as they meet the requirements of these regulations, once they are passed, then they can do it.
Well, I appreciate that, and it still means that they've got to go through these 10 hours, and these 2 hours, and these 10 hours, and these 5 hours, and these 5 hours, when they've already gone through a whole lot of training. And it just is
There isn't any
unfortunate.
other,
It's
there's no other
unfortunate
way
in
to
my
do
mind.
it.
But Karen, the midwife who hires them, can sign off that she has trained them to that point, and it doesn't matter. If she's satisfied with their training,
She's
done.
satisfied that they are qualified, but is she satisfied that she has followed the rules for all of these clock hours? Is she
She
going to be
can-
held to that standard?
She can do that by observes and training on the job. They can't just walk into it. There's no way to get there. And maybe at some point we can change that, but this isn't that point.
And really, you want to protect your own license.
Yeah.
Oh, I understand that. I do.
I mean, I don't know how a midwife coming from South Carolina who has her CPM, I don't know how much training she's had until I see what she can do. And so I'm going to have to go through with her what she knows how to do and recertify it for
Sure.
California law.
I'll
It'll work.
quit.
It'll work,
I
Karen.
won't talk about it anymore.
All right. So, seeing no more comment, no more questions, we need a motion to move this forward.
So you want a motion to move it forward with the corrections and additions as has been discussed, both through public comment and through the members on the MAC
And through council.
and through council? So moved.
Second.
Second. Oh, Carrie seconded it. Okay. Good.
All right, Ms. Lowe. Oh, any further public comments? All right, let's have a vote.
excuse me.
Ms. Ehrlich,
Aye.
Ms. Marcelin,
Yes.
Ms. Yaroslavsky, Ms. Sparvon.
Aye.
Thank you.
All right. So now comes item 7, which is an update on the implementation of Assembly Bill 1308. Ms. Webb, please.
There's still a 6B, and that's discussion
sorry.
on utilization of a midwife assistant prior to the approval of midwife assistant regulations.
That's right, you were going to clarify for us.
So we have looked at this, and if a midwife can find a midwife assistant who has been trained pursuant to 2069 and the regulations related to that section, then yes, because that meets the requirement of has had at least the minimum amount of hours of appropriate training pursuant to standards established by the board for a medical assistant pursuant to section 2069. So that's training by a physician and surgeon, CNM, and the like.
Or
Until
an MA. Yeah.
until regs
Are
are in
set.
place.
So basically, we can use a medical assistant.
Right.
Is what you're saying, until the regs for midwife assistant are in place. Okay.
So it has to be someone who a midwife can't take someone who hasn't had any medical assistant training and do
Train
the
them.
initial training.
So no trainings for midwife assistants can happen before the regulations are enacted.
But
Well, they can't be used as midwife assistants with only midwife assistant training until the regulations are enacted. If I wanted to use a medical assistant who's already been trained as a medical assistant in the capacity of a midwife assistant, I could do that?
yes.
Okay. I could train midwife assistants, but they couldn't work on the job or have on-the-job training. I could begin like the didactic portion of that. There's nothing to prohibit me from providing the educational component while we're waiting for regulations. Just, there's a prohibition against anybody using them as a midwife assistant before the regulations are adopted. Am I paraphrasing that correctly? Because that's what I'm understanding.
Oh,
This is already laid out in the statute.
well, something to keep in mind is there are things that a layperson can do.
Yeah, we've
Okay.
had a really hard
All
time
right.
ever getting the board to delineate what those were, but okay.
But you can't, I think Ms. Dobbs has some comments.
Okay, so as section 2516.5 is written now, you can use a medical assistant, and if you look at section 2516.5A, it says basically, someone who meets the requirements, which really is the requirements of a medical assistant and has a certificate. And then the section goes further to delineate certain things that your midwife assistant can do. And if you look at 2516.5,
I don't seem to have that in my book here.
B. I'm sorry?
You can look at my book.
But they are in the regulations packet.
I don't have it in my regulations packet.
14, 15.
So,
And I
okay,
don't
so
see
let me,
that
let me say it this way. So under 2516.5B, it says, notwithstanding any provision of law, a midwife assistant may do all of the following. And it goes through and lists things that a midwife assistant may do. Those things that are delineated in the statute, that are clear, you don't need regulations for, because it's already clearly placed in the statute. So certain things that are not clear, we're doing the regulations to make those things specific. And those are the regulations that are before you now. But until those passed, anything that's already delineated in the statute can go into effect today. So, for instance, if you look at B1, it says, notwithstanding any other provision of law, a midwife assistant may do all of the following. Administer medication only to intradermal, subcutaneous, and I'll stop because it's basically talking about all the things that a medical assistant can do.
But doesn't, under 2516.5A1, doesn't that section there where it says at least the minimum training and standards pursuant to section 2069 relate to that list? Because otherwise, why are we doing the 10 clock hours of administering injections if they can do them without that training?
Plus,
Which is what I'm
A1
hearing.
defines what a midwife assistant is. So, that is a,
Right, and it basically says it's someone who has the training of a medical assistant.
Right.
So basically, what we're saying is if you have someone that has the training of a medical assistant today, that they can come in and you can use them.
Okay.
All right?
That's
we're saying.
what I was hearing. I just wanted to be clear that that's what I was hearing.
I have a question in case you
Please.
forget. My name is Anne Marie Adams. I am an OBGYN practicing in the area doing home birth. As I read this, the scenario that I have in my mind is if I have a midwife assistant that I had used for the last 2 years that I have trained, because I can train them under Section 1, under Administration of Training, so I can certify to their training, then I would need to find that means I could certify them as being trained as a medical assistant. My personal, if I have a midwife assistant, I just have to find the certifying organization to do that.
No, you can do it yourself.
I can.
As a physician, you can train a medical assistant.
Yes, but
You just
but
have to
that's-
follow the medical
that's-
assistant regulations for how many hours they have to do each thing.
That's 1379.06. 1379.07 says they need approved, that there are approved certifying organizations.
So that's for midwife assistants. What
There
they're
is
telling.
not such for a medical assistant?
No, there is, but
So
it's not
doesn't
these
this
same,
mirror?
it's not these same regs. So for medical assistant as a physician, you can train them, you can certify that they've had the training that's in the medical assistant regulations. And I think, correct me if I'm wrong, but what I'm hearing legal say is that if they are trained that way, between now and when our regulations are adopted, you can use them as a midwife assistant.
Yes.
Between now and then?
Yeah, well, and even after
No
then.
past,
Right,
no
even
past,
after.
no
Yeah.
past experience. No past training counts, you're saying? If they've been training with me for the last 2 years?
No, it does count.
It does count because right now you're using them, I mean, you may call it midwife assistant, but you're basically using them as a medical assistant.
Correct.
Yes.
Yeah. And to my question about providing training that is not hands-on with patients, can that be done in the interim for midwife assistant students who have no prior training? If I wanted to, teach a class on the respective things about how you would give an intramuscular injection, for instance, without having them actually practice the skills, there's no reason that can't be done, correct?
I think you can provide didactic training, but you may not know everything that is ultimately going
Right.
to be required in the regulation.
Got that. I just want to be sure I'm not breaking the law if I decide to do it, but I don't have any plans to do it. I'm being devil's advocate here because I know the question is out there for people. So, all right. Have we answered everybody's questions satisfactorily on this issue now? Any other comments? Okay. Ms. Lowe. I think we're ready for a vote.
No vote on this one.
Oh, okay. Good. Okay. Now we're moving forward to number 7, right? Update on implementation of Assembly Bill 1308. Ms. Webb, please.
Okay, so I'm still in ongoing discussions with representatives from the midwifery community and from ACOG. There has been some interest expressed to me about trying to move forward with the regulations, even if that means having a physician consult prior to every VBAC, that maybe that's not so burdensome. Certainly, I don't know if that's representative of the majority of midwives. It's still being explored. The other things being explored are a legislative change, perhaps requiring the consult, but not requiring a physician sign-off. I'm hopeful. I'm glad the discussions are continuing. There's nothing set in writing yet, but I feel like there is positive movement.
Any input from members of the MAC?
Ms. Webb, I am unclear on what the process is that is now being advocated and what you just said. I don't quite get what's different that would make this work that hasn't been working before.
And
It's,
oh,
I'm sorry,
Go ahead.
it's maybe a change in how adamant the midwifery community has been about no prior physician consult for certain categories of VBACs. Maybe there's some flexibility to have a physician consult, and then we can explore the levels of that. What does that need to look like? And if the sign-off requirement is there, what does that need to look at? Getting to other levels involved in the statute.
I would like to say that anything that is required of the midwives and of their women will not work unless it is also required of the physicians. If the physicians are not required to give the consult, if they are not required to accept the referral, there's no way that this can work.
Well, I mean, I think that the presentation by Cam was nice to see, at least based on those who responded, that collaborative relationships are possible and can be fostered. And maybe this isn't as big of a hurdle as I originally thought.
I believe if it is a hurdle for 10% of the women in the state of California, it's too much. That we are
I
talking
think, Karen,
about
Karen,
women
I
who
want to stop
can't-
you for just a minute, because all we're working on right here is, could we do another interested parties meeting to talk about this further? That's
Yes.
really all that's on the table right now.
Okay.
We're not gonna rehash it today here because it's not the right forum. We all have super strong views about it, and I want it to have the time and space that it really deserves to have a full discussion, and I don't have the time in today's schedule to do that.
I would like to see a interested parties meeting, because I know there are many women with a lot to say.
But I would suggest that along with the interested parties meeting, that we've heard very, very clearly that there is an opportunity for collaboration here. We've had an offer from ACOG today. We've heard from the report that was presented that there are areas of the state where there is collaboration going forward. And I would suggest that this has to be done parallel, that should be going full speed ahead immediately, getting that moving and sitting down at the table to make that happen at the same time this other is going forward.
Yeah, I agree, Barbara. We need to come together on all fronts so that physicians, hospitals, and midwives are working together to provide safe, informed care regardless of the setting or the provider.
Yes.
And we can only do that if we foster those relationships and not dismiss the possibility of them ever happening out of hand on either side. So can we move forward with setting another interested parties meeting to discuss this further and maybe have some?
I'll raise this with executive, and we'll go from there.
Great. Looks like Lori Gregg would like to comment on this item.
I can wait till interested parties meeting, just about.
Thank you. All right. Are there any other comments on this agenda item, number 7? All right. I'm going to move on. Agenda item 8, update on licensed midwife annual report. Ms. Lowe.
At the December meeting, I provided an update on the LMR task force and indicated that before proceeding with the design document, we would be, as staff, sending out a survey to all licensed midwives in California and interested parties. Unfortunately, we were unable to complete that task prior to today's meeting due to limited resources and working on other projects, including the regulations. We will be getting the survey out very soon, and we will be providing an update at the next meeting. Not only will we send the survey to our licensed midwives in California, but to all of the members as well.
As in physicians or?
To all of the
the
MAC
MAC
members that
got
are
it.
not licensed midwives as well. And that concludes my update at this time.
That was easy. It is already. Yeah. Is there any public comment on this item? Any comment from the MAC members on this item? Okay, I just have one question, Ms. Lowe. I know the survey was to find out whether we could get LMs to actually use a computer to submit their data. And I'm wondering, the fact that staff didn't have time to do it yet, how far back then does that put us? Are we now into 2018 before we could implement any changes? I mean, the 2018 reporting year.
Yes, most likely at this point.
Okay.
So we're not going to be able to actually sit at our computers and do a new report until 2019?
2018, you should be able to report for 2017 if things go accordingly.
So that we're still on that hopeful schedule?
Okay.
Thank you.
Thank you. All right, no further comments. We're going to move forward. The next agenda item is Midwifery Advisory Council membership. Ms. Lowe?
At the beginning of January, board staff sent notice to all licensed midwives subscribers on the board's subscriber alert lists and posted information on the board's website indicating that the board was seeking applications from licensees and interested parties to fill 3 positions on the Midwifery Advisory Council. The vacancies included 1 licensed midwife, 1 licensed physician and surgeon, and 1 public member position. All terms would expire June 30th, 2019. Staff received 7 applications for the physician and surgeon vacancy, 6 applications for the public member vacancy, and 0 applications for the licensed midwife vacancy. Because we did not receive any applications for the vacancy for the midwife, we will be re-advertising the position at a later date. The applications would then be provided at the next MAC meeting to request a recommendation or a nomination. Following today's meeting, the nominees for the physician and surgeon and the public member position will be presented at the board meeting in May for final approval. So if there's no questions, I'll go ahead and continue. As there were no nominations for the licensed midwife position, we'll move to the licensed physician and surgeon vacancy. As mentioned, there were 7 applications submitted for the vacancy. Dr. Ann Adams, Dr. Jeffrey Martin, Dr. Sandra Mendez, Dr. Enrico Pietrantonio, Dr. David Pryber, Dr. Donna Ritchie, Dr. Alex Sofici. Prior to requesting nominations from the MAC, if there are any of the applicants in attendance who would like to address or who would like to introduce yourself and make a statement to the MAC, you're welcome to come forward now.
She's from Sacramento, I think.
Hello, I'm Dr. Sandra Mendez. I'm an OBGYN. I've been in practice in Sacramento since 1990. I currently have been in solo practice for the last 17 years. I deliver at Methodist Hospital, Sacramento, which is in South Sacramento. My practice has been very high Medi-Cal population. I'm bilingual and bicultural, so I have a very high Spanish-speaking population. My interest in being on the Midwifery Advisory Council is that I would like to promote more collegiality among all of us, and that starting out with the idea that our premise is that we want what is safe and what is best for mothers and babies being delivered, that if we all focus on that, I think we can come to a consensus of what is best practice. So I hope you will consider me for this position.
Thank you. Dr. Adams, did you want to say anything?
Hi, I'm Anne Marie Adams, and I've been licensed and practicing in the Sacramento area since 1986. I had a hospital-based OBGYN practice until about 3 years ago. Currently, I perform out-of-hospital births, and I have a great interest in, and I feel like I have an ability sometimes to sift through things and be able to come to compromise, acceptable practices and procedures. I have a good understanding of the challenges in a hospital-based practice, a great understanding, and a great understanding of challenges in the home birth arena, and currently am involved with the peer review with the midwives in the area. And I just have I think I would add something unique to the council. Thank you.
Thank you.
Okay. If there are no other applicants wishing to speak, I would now ask that the MAC make a nomination for the physician and surgeon vacancy.
I'd like to nominate Anne Marie Adams.
I'd like to second that. I think that, Dr. Adams, you're correct. I think you would add a level of knowledge that is often lacking in the physician community, simply because they have likely never even attended a home birth, let alone as the provider. And I know that I've worked in clinical practices for nearly 20 years now, since I got my license, and it gives me a level of understanding in terms of what physicians go through in an office practice and a hospital-based practice that I didn't have before I worked in that setting. And I think the same has got to be true on the other side.
Okay. At this time, we would ask for a motion to approve and recommend Dr. Anne Marie Adams to the full board for final approval.
So
So
moved.
moved. Second.
And is there any public comment? Okay. I will now take a roll call vote. Ms. Ehrlich?
Aye.
Ms. Marcelin?
Aye.
Ms. Yaroslavsky? Ms. Sparvan?
Aye.
Thank you.
Thank you.
And may I just thank Dr. Mendez for coming, and if we didn't have
Yes, indeed.
more room, we would certainly welcome you. Thank you for showing up, because that's one of our sort of requirements for being here. And we enjoyed talking with you, and we hope that you keep midwives in mind and find some way, other than being on the MAC, to continue the dialogue. Thank you very much.
Yes, I'd echo that, Dr. Mendez. And it seems to me that there has been a lot of discussion today about how members of the physician community that are doing births can interface with us in terms of helping to create best practices for transfers from home to hospital, for collaboration when we need to refer somebody. And I would really encourage you and the midwives that are Sacramento midwives to interface together and see if there's ways that you can assist each other in that. Please.
Well, I hope I'm not out of line, but one thing I would like to comment on that was discussed earlier in the agenda in terms of the survey of having physicians, obstetricians who are open to referrals and who, the one, and bringing this information about, 1308 to the physicians, bringing it to the hospitals. The other group that you need to bring this information to is the medical malpractice carriers, because those are the ones that are limiting me from being able to participate in home births. And so it doesn't matter how much I may want to support home births. I can't have malpractice coverage unless I say I'm not covering home births. So, and the same thing with hospitals. So I think
We
that would
totally
be
understand that.
a third prong in your information is to go to the malpractice carriers and educate them as to what certified and licensed midwives do.
Thank you for that.
Thank you very much.
If
Thank
you
you
have-
again for being here.
And if you have any ideas about how to approach the malpractice carriers, because there have been times that we have tried and we get brick walls. Yeah, so, and we can continue to try.
All right.
Okay, so I'll now move on to the vacant member position. As mentioned, there were 6 applications received for this vacancy. Julia Golden Blackburn, Patricia Bradshaw, Ann Doan, Jocelyn Dugan, Denise Ellison, and Jennifer Kamel. Prior to requesting nominations from the MAC, if there are any of the applicants in attendance and would like to introduce yourself and make a statement to the MAC, you may come forward now.
Hello, everybody. My name is Jocelyn Dugan, and I have a very personal connection to midwives. And professionally, I've been working with midwives across the state for about 5 or 6 years in various capacity. Most notably, I've served as the treasurer for the California Association of Midwives, and I envision a place where we can take midwifery. Honestly, this work is so important to me. It's one of my passions in life, but I see that keeping the mother and the baby safe and having good outcomes is of paramount importance. And in doing so, developing and maintaining a high-quality standard of care for midwives across the state is one of the things that I consider vital in getting these outcomes and then compiling data and educating people. So I'm really happy to sit here before you. I hope that you will consider my application seriously. I know that I bring a unique perspective in the public position because I know midwifery inside and out, from the accounting side to the touchy-feely side. And I am honored to be here. Thank you.
Okay, I just have a question. Are you still on the CAM board or as the treasurer or not?
Yes.
Thank you. All right, anyone else present?
Okay.
Okay.
If you could now nominate a public member for the vacant public member position.
I nominate Jocelyn Dugan.
Well, I just have a question. Is there a conflict with having
Yeah.
someone from the CAM board on the MAC?
I'm reluctant to. I noticed that there's also someone from the Board of California Families for Access to Midwives who applied, and just as I think it would be a conflict to have somebody who is, for instance, the Region 9 rep for ACOG as the member on the MAC, I personally feel like there's that the ability to have others criticize because of this double hat that's being worn is there, and I'd rather avoid public criticism. I know that Jocelyn is the only person that came today. Jennifer Kamel also has applied, and she has been to a number of MAC meetings and presented. She has spoken before the medical board, and she did send me an email saying that she was just unable to make the meeting today. She lives in Southern California. So in terms of her demonstrated interest over the last few years, that would be my
But
choice.
Doesn't she also sit on the board of a?
I can.
No, she has her own organization which is involved in informing women about the risks and benefits of vaginal birth after cesarean, but it's not a nonprofit that works to further the rights of midwives.
Is there a legal opinion that we should listen to?
The statute.
Your mic is off.
Thank you. The statute setting up the MAC does not put any limitations on who can be the public member. So it's it's, Ms. Dugan isn't disqualified pursuant to the statute, so that is not a barrier. It's really up to the MAC who they're going to nominate and vote for. So I just wanted to clarify that.
I would like to add that when we first formed this council, that among the public members were 2 obstetricians, and they obviously have a certain bias. That I think that this is, the fact that this is actually a public member would, in my mind, make Ms. Dugan even more qualified than those physicians who were originally seated on this council.
And additionally, when we think of conflict, we look to see whether or not it's an actual conflict or, there's a perception. And generally, when people serve on boards, they usually have some sort of interest in the subject matter. So that's common. What we need to make sure is that for anybody who serves on a board, that they make sure that when they're sitting on the board, that their focus is the mission of that board and not any other outside interest. So that's something that all members who serve on the board have to do constantly anyway. So she isn't precluded as a result of her position on that other board.
May I say a couple of things? So first of all, I know Ms. Dugan quite well, and I can vouch for her integrity. But also just to remind you all that CAM will be bifurcating, and she will remain on the 501c3 board. And there will be a separate board that represents midwives as a trade association. But also, historically, we had Faith Gibson on the MAC for many years, who was represented California College of Midwives. Anyway, that's all.
I didn't mean to suggest that Jocelyn's integrity would somehow be impinged here. What I'd like to avoid is the public perception of a conflict of interest.
I appreciate Carrie's concern, and I will renominate Jocelyn Dugan. I believe that she is quite capable of keeping incredibly strong ethics in terms of representing the public rather than any other interest group. I repeat my nomination.
And I'll second her nomination, since she showed up and she lives closer.
Okay. Is there a motion to approve Jocelyn Dugan for the vacant public member position?
So moved.
Yes.
Was that a second?
Yes.
You got a second down there. Is there any public comment? Okay, I'll take a roll call vote. Ms. Ehrlich?
Aye.
Ms. Marcelin?
Aye.
Ms. Yarsofsky? Ms. Sparvon?
Nay.
Thank you.
Thank you. All right.
May I make one statement, a little bit of a statement here on the fact of there being no midwife who made an application? I specifically did not because I don't want to be on this council anymore, but after 9 years, it seemed like it was appropriate to let some new blood come onto the council. My lesson in this is go ahead and apply, because I could always withdraw an application where apparently I may not currently ask to be to have my term extended or to be accepted, given that my term is officially up. Either of those would be my preference, because I would prefer to see this council continue in its full complement of people.
You can reapply. I think we need to stick with the.
I realize that I can reapply, but I can't do that here and now.
Process is closed.
I accept that. I'm not saying that. I'm saying that the term, given that we have played with the terms on the council already, and that there has been nobody who has applied, I wonder whether it wouldn't be more effective for the medical board staff to not have to go through another round of reapplications now when there will be another round coming up in less than a year from now. And just to go ahead and re-extend a term so that we don't have a period of time where we don't have a full complement on this council.
Karen, I think
So
that
that's-
I think that one of the ways that can be dealt with is to ask the board to allow us to seat the newly appointed person at the August meeting. We've done that before. I think we did it when we have appointed Tosi. So
And
I don't anticipate us being short a midwife in August.
I'm saying, okay, all I'm saying is that it seems like redundant for the staff to have to do this again.
Yeah, but there isn't
now.
any way around it.
Correct.
They-
We received no applications. We have to open the process up again to allow anyone else who wants to apply.
I just know that we have not.
You're trying to make it nice, but it's not gonna work.
It's not going to work to make it nice. Okay. I'm going to
Sorry about
apply the next time so that this doesn't happen again. Just so people know that, I'm not going to let this happen again.
Okay.
All right.
So that does conclude the agenda item.
All right. So item 10, program update, Ms. Lowe.
Okay. If you could please refer to tab 10 of your packets, we provide the licensing and enforcement statistics. The licensing statistics are the usual statistics that we provide now at every meeting. There's nothing that stands out too much. We continue to receive an average amount of applications per quarter. We've provided the license statuses for the entire licensing population for midwives, but I don't really have anything else to provide to you. Are there any questions on the licensing statistics?
So as of June, a year ago, almost a year ago, we had 361 current, and I am reading that correctly.
Are you talking about the chart at the very bottom of the page?
Yes, I am.
So that is a snapshot at the end of each fiscal quarter, of each fiscal year of the total licensing population. So at the end of each fiscal year, those are the different buckets that each license fell into.
Okay.
It's not additional licenses per year, it is at the time, what status were they in?
So there were 361 current at the end of fiscal year 15.
Correct.
Thank you.
I have a question, just as to process, to looking at this. It would be, from my eyes, easier to see everything, the most recent on the left side, and everything on the older side on the right side. So like in the first one, you've got the licensed midwives, 15, 16, and licensed midwife, it goes down to 10, 11. Over on the right is 14, 15. So if you put 14, 15, okay, and the same thing below on in the last chart as well.
Reverse the order.
Reverse the order, so instead of 6:30 to 11?
Yep.
Okay, thank you.
Okay, so I'm going to go ahead and continue with the enforcement statistics, which is provided on the next page of your packets. For the enforcement charts, we have made a couple minor edits to the report, which was discussed at the last MAC meeting. We've changed the title, was previously listed number of open investigations to total number of complaints referred for investigation to help clarify what that number is representing. We also added total number of investigations currently open to capture the number of investigations that are pending. Now, we did not want to say number of investigations pending because we did not want to infer that those had not started the investigative process. So it is investigations currently open. Are there any questions on those two minor changes? Okay. As you can see in the chart provided, we received one complaint during the quarter, and there were no referrals for disciplinary action during the time. We did receive 29 hospital reporting forms, for a total of 62 forms received so far in the fiscal year. In regards to the hospital reporting forms, staff feels that it's important to provide some clarification on the board's process for handling the mandatory reporting forms. Business and Professions Code Section 2510 requires a hospital to report each transfer by a licensed midwife of a planned out-of-hospital birth to the board and to the California Maternal Quality Care Collaborative. Upon receipt of the form, board staff review the information provided and determines what action is required, if any. Just like with any other information that's brought to the board's attention, if it appears that additional review is warranted, for example, an egregious act is documented on the form, a complaint will be initiated. This does not mean that the board initiates an investigation. As you are all aware, the mission of the board is to protect healthcare consumers. If the board failed to obtain additional information or to begin an investigation based on egregious information presented, we would not be fulfilling that mission. In addition, if the board were to obtain information regarding any other licensee of another board or bureau, as a consumer protection agency, it is our responsibility to provide that other board with the information presented. This would allow them the same opportunity to review and take appropriate action if needed. Although we have separated the statistics on the reporting forms from the data related to complaints, we do feel that they should not be reflected under enforcement statistics. So for future meetings, we will be presenting the hospital reporting forms in their own section to help further clarify that it is not necessarily an enforcement issue.
I have a question. Instead of having licensed and unlicensed midwives lumped together, and I assume CNMs are in there somewheres probably, could we have it delineated out? How many did you receive on licensed midwives? How many did you receive on unlicensed midwives? And how many were for CNMs? So that, because
Well, CNMs would fall under unlicensed midwives, so we can separate the two.
Yeah, I think that's a different, yeah, I think we need to separate the two. We need to know whether you got the form on a CNM who holds a certificate to practice in the state, or you got the form on somebody who's wholly unlicensed completely to practice midwifery in the state.
Well, hopefully we will never receive a form on an unlicensed person transferring someone for an out-of-hospital birth, but if we do, we can obviously report it
Yeah, if we
separately,
could
so.
just have it broken down, so we know how
Yes.
many of these actually belong to licensed midwives. And I have a question. If you receive a hospital reporting form in error on a certified nurse midwife, why couldn't that just as easily be returned to the hospital that sent it with the query that they're not required to report it on CNMs, and if they wanted to file a complaint, here's the address they can send the complaint to, rather than forwarding the form itself as a complaint to their board?
So, first of all, the board's business processes will be changed so that it is clear that it is not a complaint that has been received. If we receive information, regardless if it's on the mandatory reporting form, or if it's a newspaper clipping, or if somebody brings it to the attention, it is our responsibility to review it, triage it, see what additional information is needed or what type of review is required. As I mentioned, if it pertains to another licensee of another board or bureau, we need to provide that information to them, just like they would need to provide information to us if they receive it. It's a consumer protection issue, and that is the main mission of the medical board, and that is why we would do what we would do.
But what you're saying then is that say it was a nurse midwife that got reported to you on a hospital reporting form, and there was nothing that anybody did wrong, but you don't feel like you have to send that form over to the nursing board.
It would be information pertaining to their licensee, and we would provide it. Regardless of what is on that form, they don't necessarily have to, just like us, initiate an investigation, but they have the ability, and they should be reviewing information provided for a licensee of their board.
When the law was
What else is being done with these forms besides looking at them to see if they warrant investigation? Is any statistical data being compiled? Because when we first worked on the hospital reporting form, it was seen, or at least sold to the midwives as, this is good, this is going to help inform more communication between midwives and hospitals. We'll be getting data from this that we can use in some way to benefit not only consumers, but of course the midwifery community. And so if you're only using it to mine it for data of who did what wrong, then what happened to the other purposes for which this was designed?
Okay, so currently, we are somewhat limited on the data that we can collect because there have not been regulations created to define what can be requested on this form. As you may recall, we had a few interested parties meeting. We had different agencies providing their requested information that they wanted included on the form, and maybe Ms. Webb can help me out on the process where we're at now. At some point, once those regulations are drafted and we're able to define what can be requested, it will be used for additional statistical purposes. At this time, we are tracking the reports that we receive, and based on the information that is currently on the reports, we're able to determine the type of we're able to determine that midwives are not performing services that they shouldn't be to some levels, including multiples and issues related to VBACs for certain issues. It's not just an enforcement type issue. That is not the only purpose of the form. And again, once we have additional regulations to define what other items that we can be requesting, we'll be able to use the form for additional purposes. I hope that helps clarify somewhat.
That helps. I just want to know who's working on the regs, and are there interested parties meetings scheduled for that?
There's not currently an interested parties meeting set up at this time. And do we have any additional updates from this, or?
What's the timeline?
There's not one set yet. The California Hospital Association put the brakes on the form that a number of other agencies had reached an agreement on, and then they didn't show up to the interested parties meetings. And so there needs to be further discussion with the California Hospital Association, and we want to avoid having the regulations derailed at a later point.
Mm-hmm.
When this law was passed that authorized the hospital transfer form to be put together and started to be used, my understanding was that this was primarily for information, that it was not for enforcement and it was not for complaints. And I am really upset that this is going to the central complaint unit. I am really upset that it is going to be looked at as a way of initiating investigations. And I am especially upset that it is being used against a different profession that is not under the purview of the medical board. I recognize what you're saying about this being for consumer protection, but the Board of Registered Nursing is quite capable of asking for a law to be passed, so that it can track its own licensees, and is quite capable of starting its own investigations. I really believe that, first of all, these should never have gone to the central complaint unit, ever, any of the transport forms. I believe that these belong in the purview of the executive part of the midwifery program, and that anybody for whom a mistaken report is sent to the medical board by mistake, in error, they should be shredded, quite honestly. But I could accept what Carrie is saying. Let's send it back to them and say, this is not correct. This should never have been sent to us. It should never have been filled out, because it is not required by law. There is something really wrong here about how this has been implemented, and I register my extreme displeasure.
Okay. Let me let Kurt Warden speak to us here for a minute. Chief of Licensing.
How we operate the board and where we send information to be reviewed is down within the executive office of how we operate the board. All required reporting documents go into the consumer complaint unit. Okay, that is how we operate. That's how it's going to continue to operate. And the forms were not intended necessarily to be actual complaints, and some of our letters are going to be modified so they're not saying they're complaints, but they are tracked as an open complaint because we have to track them in a system. That doesn't mean the midwife's going to be contacted by the board. It doesn't mean there's a formal investigation. But if the Central Complaint Unit identifies a problem that is a consumer protection issue, a complaint will be opened, and it will be looked at, depending on what that is. If the board receives information, as Ms. Loeb had previously stated, from any source that has to do with consumer protection or another board's or bureau's licensee, all boards and bureaus are required to submit that to those licensees' official board for consumer protection purposes. How that board chooses to use that form or chooses to open an investigation or chooses not to is how they operate their board for their licensees. So to be upset about how we do business, you're not taking consumer protection into consideration. And this is this board's responsibility is consumer protection first. And that's what we will do first.
Okay, my other question then would be, is there some direction to the hospitals about these forms that if they want to make a complaint, they should follow the complaint process and not see these forms as a vehicle for complaint?
How people submit complaints to any of the boards, especially within the Department of Consumer Affairs, people can submit them on formal complaint forms, a written piece of paper, even submitting the wrong form, as long as we can identify what it is. That is consumer protection. This is how the Department of Consumer Affairs operates. This is how the board operates. This is how all the bureaus within DCA operate. I've worked for the Department of Consumer Affairs for over 25, almost 26 years. I've worked at multiple places within DCA. This is a consumer protection issue. Yes, you licensees are a client of ours, but the main mission is the consumer's protection, and we will continue to do that until you want additional stats, as Ms. Lowe said. When the form gets developed to a point where we can collect those stats, then that will be an appropriate thing to use additional. At that point in time, then we'll take that in consideration. But right now, with the way that form is, very little data is useful on it. So to provide any additional information is not going to really happen. So it sounds like I'm being harsh, but this is the reality, and I'm just wanting to sort of end that conversation.
So let me ask for clarification. Okay, let's have a little bit, take a deep breath, everybody. Deep breath. Clarification. Ms. Lowe, you originally said that the page that we're looking at is going to be reported differently with different titles. Is that correct? Just the top?
The statistics will
Right.
be
So it's
reported
going to be,
differently.
okay. My question is specifically on the licensed and unlicensed midwife, the last one.
Yes.
Hospital reporting forms received. What does that mean?
That
You
means
received what?
how many of that specific form was submitted from a
hospitals.
hospital,
That stated?
whether it was for a licensed midwife, an unlicensed person of the board. So that could be a certified nurse midwife, or it could be a completely unlicensed person. This is simply the forms were submitted and they were entered into our database for triage and review.
Let me just recap for the public and Barbara
That's what I'm
maybe.
try- that's what I'm trying to get
The
done.
form was developed through interested parties meeting. It was required by AB 1308 so that every time there was a transfer from home to hospital by a licensed midwife, that got documented by the hospital, and that form is required to be sent to the medical board. I think, does that answer your question? That's what
just
that's what
about.
those forms are.
Just about, because what I'm hearing and what I've heard and what I thought to be true was not that it was a method of discipline or unhappy treatment or inappropriate behavior.
It's not.
It was just the number of babies that were being transferred, period.
Absolutely.
Is that correct?
Mothers
Is that
or
correct?
That is correct.
Yes.
And
Is
the
that
fact
correct?
that these reports
So
are
that it has
being-
nothing to do with any kind of discipline, it has nothing to do with bad outcomes, it has nothing to do with she wore pink shoes instead of green shoes. It's just FYI, this is the number of babies that were transferred from home birth to hospital birth. Is that correct?
That is correct.
So what is the problem here?
So I think the problem is
Yes, I'm listening.
that it was not the understanding of the licensed midwifery community that this is how the form would be tracked and how it would be viewed within the department. And I think that's where all the pushback is coming from. I think it would be really helpful, Mr. Warden, if you could tell us what other kinds of forms you handle that are of a similar nature, maybe for other licensees that come in and you have to triage in a similar way.
Well, the physicians have mandatory reporting. Hospitals have mandatory reporting on physicians. All of those forms go into the central complaint unit and are reviewed. For the
Court reporters have mandatory reporting.
There's
District
many-
attorneys, everybody, there's lots of mandatory reporting.
And those are reviewed just in the same way. Not every one of them turns into a complaint. Not every one of them turns into an investigation. But there are some that do, and that is exactly what's the same.
So what I just want to, what I'm just trying to explain very carefully is this, is that the entity that gets the materials from the postal delivery person in the mailroom is titled that. So this is just a title, a working title of the Medical Board of California. It has nothing to do with a negative sign. So it's like, they could title it ice cream carriers, and they're going to do the same job. They're going to look at the things that come in, they're going to take a look and see if it's warranted to be anywhere or done anything with, and they move on. You're putting them all together as it's
I think to help people,
assumptions.
I just want to rephrase this for a second, because right now we're talking about midwives on our hospital reporting form and certified nurse midwives accidentally getting reported and then that going to their board. How would we feel if one of the reporting forms for a physician came in and there was something egregious on it and the medical board did nothing? We wouldn't like that a whole lot. So I think we need to keep it in context. We need to realize that the legislature told the medical board they had to collect these things. They didn't give them a lot of specifics about what they were really supposed to do with them, but they're supposed to collect them, and they can't just put them in a box somewhere and ignore them. They have to look at them, they have to read them, they have to decide what to do with them, and as Mr. Warden has explained, this is the process that exists. And nobody asked us how we'd like it to be. I'm sure they didn't ask you how you'd like it to be. It just is the process, right? And so we have to live with what the process is. My only regret is that it wasn't clear 2 years ago how the forms were going to be handled, because then we wouldn't be having this discussion now. But now we're all clear. We know that the box that it goes in is the central complaint unit, and if they get one that has another licensee from another board on it, they have to do something with it. It's not that they say, here's, we got, it's a complaint necessarily, and things are going to be relanguaged, right? The wording on your documents is going to remove the word complaint, if I understand it correctly, so that it's just a form.
The language is going to be revised so it's a little clearer.
Thank you.
And also, it's not just, getting a form that was about a certified nurse midwife or anything else. We get forms sometimes complaining about contractors or auto mechanics or whatever. Those go to the appropriate boards too.
Got it. So it's not that they're trying to persecute us, and we need to begin to come out of that mode. And I know that a lot of midwives, or at least a significant number of midwives sitting in this room, practiced before we had the ability to be licensed, and it's a real hot button when we think we're being persecuted. That isn't the world we live in anymore. We now have licenses. The medical board's not out to get us. They're out to help us, and I think they've demonstrated that over and over again, and I'm really thankful for it.
I think it's pretty clear, those of you who know me, that I'm very supportive of the midwife community. But I am not so supportive when it comes to not wanting to do consumer protection.
I don't think that was the issue.
That is not the issue.
I don't think that's the issue.
That is not the issue.
We are for consumer protection. It's just that there was this big gap in what people understood was going to happen with them, which I think probably was really vague in all of our heads, and what actually we found out was happening with them, and it was a hot button for people.
And it's also a question of We thought these were going to be helpful, but there's no regs to make them helpful. So the midwifery community has bent over backwards to make these forms work. I mean, most of the hospitals, when we transfer in, they have no idea that these forms exist or that they should fill them out or anything about them. We carry them and give them to them. I mean, we're participating as much as we can.
Yep.
And we would really like, when we get to the regulatory process, to have some input from the midwife as well on the form. It not just be, I
Midwives
know
have
that.
had input on the form in
So-
the past.
Yeah,
So
yeah,
that's
So let
Exactly.
me ask the question, so we're all clear on this bottom thing. The only thing that I'm reading from this bottom thing is not where you guys are coming from at all, but just that, in fact, 62 babies were transferred in Q1 and Q2. Is that correct? And the end of conversation, correct?
Mothers and babies.
Mothers and babies,
Well,
yeah,
usually they go together, hopefully.
usually.
Usually, sometimes they're not walking
How
in.
many reports we received from the hospital telling us
Meaning
that?
that's, how many reports mean how many have been transferred?
Hopefully.
And
If
it could be
they're
just a
or
mother
they're
because she
providing
was
us a
bleeding,
report.
or a
But there's-
baby because it wasn't
There's
breathing
nothing else,
well.
there's nothing else, just that they've been transferred.
Yes,
So don't go down all these other pathways.
we had to.
Okay, I don't know about that.
No, we did.
Is there a possibility that in the revision of this language that you're talking about, there could be a line on it that says, this is not a complaint, this is a tracking document? If you have a complaint,
It's not going to say it's a tracking document. No.
And it wouldn't
then what would
matter.
it say? If you have a complaint, you must go further. This is not a
It
vehicle
wouldn't
for
matter, though,
complaint.
Karen. It wouldn't
No.
matter. Because
the-
they're still gonna review it to see whether an investigation is warranted.
Excuse me. So let's be careful that we don't stray into that agenda item because it's not agendized.
Thank you. All right. So my next question is, what is the timeline for adding more to the form? Because I thought we had all decided that we weren't going to put anything else on it. But maybe I'm wrong there. And I know you guys are really strapped for time, so.
It's,
And
we
it's
didn't put
not a time
anything else
pinch.
on it because the form that we tried to put through was objected to. And so then we had to go to the form that only the statute requirements on. So it
Okay.
couldn't add all the other things that you wanted to collect.
Got it.
Right, and that was what Ms. Webb was talking about when the Hospital Association objected to the form. Okay, so the form is in its current position because of that objection, because what's on the form is required by statute. To add additional stuff, it would require regulation.
Okay. Maybe we could
we
talk
need-
some more
if-
about it off
if-
out of this forum or something, yeah.
If the additional information is still important, then we need to schedule an interested parties meeting, but we need to have the Hospital Association actually participate.
Right. Well,
So that we have their input on it, because we have the input that was provided in the past from the midwives, which was fairly detailed. And
I'd just like.
that's not where we're at. And so I will talk with Ms. Kirkmeyer about seeing if we can get that moving forward.
Yeah, I'd like to at least see in terms of reason for transfer to hospital, that they have the same reasons and they're just check boxes that match up with the LMAR reasons for transfer, so that we can have some sort of correlation between the two things. Are we,
We
we're off?
shouldn't be
You
discussing
can't, Carrie, that's what I'm trying to.
Okay.
modifications to the form.
Okay.
When it comes
So,
down to that, when it comes to
okay, thank you. I have a comment on this item.
My name is Nancy Myrick, and I'm a certified nurse midwife practicing home birth in the San Francisco area. And I wanted to first thank the medical board for making consumer protection a priority. It is a priority for me as well. But I do think it is important to understand how this process plays out in the real world. And I want to use my case as an example of that I had a very straightforward, normal transfer to Marin General Hospital on January 8th. And they incorrectly submitted a hospital transfer form to the medical board. As a CNM, that's obviously not required because I'm not licensed through the medical board. The medical board then received that, and my understanding is that it was routinely sent to the central complaint unit, who discovered that I am not a licensed midwife and I am a CNM, and then sent it on, as the gentleman said, to the BRN. But in translation, that sounds like this. The Medical Board of California is only authorized to take action against an individual it finds in violation of the Medical Practice Act. Your complaint does not fall within our jurisdiction because your complaint is not about medical care and treatment provided by a midwife licensed by the medical board. Therefore, your complaint concerns a matter which would fall within the jurisdiction of the Board of Registered Nursing. I am forwarding your complaint information to the address shown below for action they deem appropriate. So something that was not a complaint, that actually was a smooth and appropriate transfer, gets translated through the entities and ends up being sent to my board, which might be slightly less friendly than the medical board about out-of-hospital birth, as a complaint. And here I, through the generosity of a person at the hospital that sent the original report, get informed that now I have a complaint that was submitted about me to my licensing board, the Board of Registered Nurses. So this is, to me, how this process, with the absolute best of intent, ends up being a complicated problem.
Yeah, I think that's where the language revisions are going to come in.
So, and if I can chime in here for just a second, that's one of the things that this obviously was not, I won't say a learning experience, but it, brought it to our attention. And the letter that was sent out is a system-generated letter from the system when we are sending the document from that unit to another unit or board. So that is one of the things that we will be working on, is revising the language to make it appropriate for these types of reports.
And I just want to add two other things that might be looked at. If it is a standard hospital transfer report that has no complaint on it, which this one clearly didn't, that it actually be returned to the hospital and say, you incorrectly filed this. I mean, if there is a complaint on it, and I understand from a consumer protection intent that it would be appropriate to follow it up, but if there is clearly no complaint on it, then it could stop there. And my second point is that for this form in nowhere says that this is not for CNMs. And there are several points, and I know the form is not on the table, but I think it really feeds into this, that it definitely seems small m licensed midwife, and is being perceived of on a hospital level as something for any midwife who has any sort of licensure. And that is completely not clear and is detrimental to me and my profession.
So I think that what we have to expect is that staff is going to go back with what they've heard and take a look at the formats and take a look at revising the use of and the explanation of that form so that there isn't a blanket, maybe they're pulled out, but that's for staff to decide. And I personally appreciate what you've said, but I think that we have to defer to hearing these kinds of issues and letting staff handle them. That's not for us to be doing.
And maybe it's time for the board to again send the form with a letter to all the hospitals in California that have obstetric units to alert them that the form exists and they should be using it for licensed midwives and what the purpose is.
It may be something as simple as when that form goes in hand I'm hearing that midwives also hand in the form. That they don't.
No, we're not
Okay, I didn't know.
required to.
Required to.
Forget, okay. I never said anything.
All right. Ms. Walsh?
Do it out of the goodness of our heart.
My name is Linda Walsh, and I'm president of the California Nurse Midwives Association. Our association, first of all, I appreciate the clarification that we've gotten today. But we actually did submit a letter to Ms. Kirkmeyer today regarding our concerns about this. I am going to highly edit it. And just, we've touched on several of these already, but the CNMA is concerned about the following. The first, the whole issue that they are filed as complaints. And I think we've talked about that ad nauseum at this point. But I do want to stress that safe hospital transfers from out-of-hospital settings are a critical component of our out-of-hospital care. And if the form is perceived as punitive, this will negatively impact patient care. Midwifery guidelines for the provision of home birth services recognize that smooth hospital transfer is an essential component of being able to provide safe out-of-hospital birth. Our second concern is that the physicians and hospital staff are incorrectly completing these forms for all out-of-hospital transfers. And the law mandates that these forms are for licensed midwives, not nurse midwives, as we've discussed. CNM believes that the medical board is responsible for educating physicians and hospitals in how to correctly complete the form, including which providers, and language according to, or consistent with previous comments. The language on the form should clearly identify the type of provider for which the form should be submitted. Also, it should be considered that the transfer forms contain patient information, and improperly completed and transmitted forms, for example, for a nurse midwife, may be in violation of HIPAA. And the third thing is that the medical board is forwarding the forms to the BRN. Should a complaint against a nurse midwife be brought to the medical board in error, it is appropriate for the medical board to forward such complaints to the BRN. However, the transfer form does not constitute a complaint, and the BRN does not collect transfer forms for nurse midwives. If the medical board receives a transfer form for a nurse midwife transfer, this is an error, and the transferred form should be discarded. Similarly, if CMQCC receives a transfer form for a nurse midwife transfer, this is an error, and the home transfer form should be discarded. CNMA appreciates your attention to these concerns, and we look forward to working with the Medical Board of California to correct this situation in a way that honors the law, the responsibilities of the Medical Board for California, and avoids unnecessary disciplinary actions on nurse midwives acting within their scope of practice. And this was sent out over my signature and Kim Doe's signature as the chair of our Health Policies Committee.
Thank you. Thank you. Ms. Boland?
Kate Boland, home birth midwife. I am a licensed, certified nurse midwife. I am licensed as an RN, and I'm licensed as a certified nurse midwife. And so I have a problem on the form that says unlicensed midwives may include nurse midwives, because that's not an accurate description of my profession. Also, I luckily work in a very small hospital where they've known me for decades. And after this law was passed, I went in with an appropriate transfer with a very good outcome. And the secretary comes up to me with the form to fill it out. And I explained to her that she didn't have to do that for me. And it probably took 30 minutes and me repeating it 5 times before she understood the difference between a licensed midwife and a certified nurse midwife, and that the form was only for licensed midwives. So this is a point of education. And what happened to this woman, you know, our registered board of nursing has some people in it who have said publicly that if they hear a nurse midwife is doing home birth, they're going to go after them, and they're a lawyer. And so I take this very, very seriously as threatening my profession and my sister professionals. This is not, you know, I'm all for consumer affairs and protection of mothers and babies and good outcomes. But when there is no law requiring this, and it's a violation, like Linda said, of HIPAA.
It's not. I just want to be clear, it's not a violation of HIPAA, no.
It's.
Why is it not a violation?
Well, anyway, I don't want to go there right now.
We can't go there.
No, let's not go there. I just want to say this is very serious to send a form on that is not a complaint and is inappropriately filled out on the wrong person. Now, if it were a complaint, if somebody there were saying, oh, this was a terrible transfer, it's a horrible outcome, then that might be a reason to send it on. But a reporting form for another license and another law should not go any place but the shredder.
And if I could
Thank
just
you.
add to what
Thank you,
Kate
Kate.
said, in the duty of, yeah, it's on, but maybe I'm not talking good enough. In the duty of the medical board to protect consumers, what kind of protection do women and babies have when their midwives have to spend extra time in
And much money.
litigation, money, and a
Defending their license.
yeah, exactly. Thank you, Kate.
I'm sorry.
Look, I understand that this is a advisory committee meeting, and to be honest with you, that's the purpose of us being sitting here. But it's also not a time to have this back and forth and back and forth. It's just, it doesn't work. I mean,
Okay,
we have to hear from you, they have to hear, we have to talk to them, and it's like, there's this.
Okay, thank you.
There's got to be some kind of appropriate, sorry. Thank you.
Faith, did you have a comment?
No, you come up here and make a comment. Come on, Carrie, this is.
She's moving. Give her a minute.
I know that the last page of the report, which has the patient's name on it, client's name on it, is removed before it is sent to the maternity quality, California maternity quality people. I'm kind of assuming that the same thing would be true if it were sent to any place else. I don't know that for sure, but I think that's the answer to the HIPAA issue. I'm not sure.
It's regulatory boards can share information with other regulatory boards, and it is not a HIPAA violation. Regulatory boards are not a covered entity under HIPAA.
So in other words, the patient information does go forward to, in this case, the BRN.
Yes, it would.
All right. I was wrong then. Thank you.
Thank you for clarifying that. Any other public comments on this agenda item? Any other comments from the MAC? Seeing none, we're going to move forward. Agenda item 11 is agenda items for the August 18th MAC meeting.
So let's put clarification of this form on the agenda for the next meeting.
Oh, it's there, honey. I've got it. In addition to the update from the chair, an update on the midwifery program, an update on AB 1308, and an update on the LMAR, I would also like an update on progress that we may or may not have achieved yet on crafting regulations for the transfer form or looking at revising it so that it's clear that it's just for licensed midwives, so that we can have a discussion, a bigger discussion about what might happen. Or if you'd like to have an interested parties meeting between now and then, we could do that too.
We also have a
Or instead.
update on the progress of a collaborative effort, joint effort in reaching out to hospitals and necessary partners as to what we were offered to before by ACOG.
I think
So
that,
I want to hear that it's moving forward and what the progress
yeah,
is.
could we,
That's a 1308 reg updates, same thing, right?
Same thing, if that's the same thing, fine.
okay, we could call it that. I'll go with that. Do any other MAC members have something that they'd like? I wanted to actually ask Calm, it would be Calm, right, to come back about the quality care stuff and give us a report on that. Rosanna sort of touched on it in her report today for the, that they're moving forward with writing standards of care and what have you, and it would be really nice to have an update on where you guys are with that. Tell me again what you called that.
California Association of Licensed Midwives and Quality Care Program.
But I would also suggest that if anyone has other items that they want to address and have listed on the agenda, that they should either through you or through staff, contact them, and we're happy to put whatever's necessary on the agenda.
Just let me know. I have to ask the board for it,
We'll
for the
also-
agenda items.
We'll also need nomination for the vacant license.
Oh, right. The LM spot, okay. Seems to me like there was something else, but I can't remember what it was now. Oh, we have to review the minutes from the December meeting. Yeah. All right, and we also need an update on the regulatory process for the midwife assistant language, yeah? That doesn't go anywhere else, right? All right. Anything from anyone else? All right. Any comments from the public? Seeing none. All right. Since there's no further public comment or order of business, this meeting's adjourned. Thank you all for keeping your tempers in check and making a productive meeting.